Hello, good morning, good afternoon, and good evening for everyone who's joining us. Thank you all for joining today in the Aspen Health For All conversation, and many thanks to Katie and Peggy Clark for hosting this session. My name is Alice from Johnson & Johnson, and I'm pleased to be your moderator for today, joined by two amazing nurse innovators who are working on the front lines every day and during the COVID crisis. This topic that we're going to cover is a really big one, and we're going to try to get to questions as well. So keep those in the back of your mind. It's very much around nurse innovators and how nurse innovators, and I'll add midwives, are leading the way towards health equity. And we'll tackle this in a couple of ways, but want to ground it first in a couple of statistics out there. So many of you know some of the inequities out. One, around 6 million nurses that are needed to achieve global health targets based on the WHO's State of the Nursing Report. Nursing remains a highly gendered profession with associated biases in the workplace, with 90% of the nurse workforce being female, but only a few leadership positions really being held by nurses or women. And finally, some of the troubling data coming out, whether it be around the American Public Media Research Lab or otherwise, finding COVID-19 mortality rates amongst Black Americans 2.5 times higher, Latinos 2.6 times higher, and Asians 2.7 times higher than the rate for whites. And so these are big statistics, big numbers. We're going to try to tackle some of it today and get some insights for those who are closest to the action. And with that, I'd like to introduce our first speaker and introduce her bio. Her name is Dr. Marc Julmisse. She is a Chief Nursing Officer and a Chief Operating Officer for the Hôpital Universitaire de Marie-Balais. And she joins us from Haiti. You may hear some noise in the background as she literally is on the front line, but she's responsible for the nursing services at HUM, leads over 400 staff members, and is also a deputy COO. She shares many hats, many responsibilities out there. And with that, let me introduce Marc and ask her for the first question. And apologies, not a doctor yet, but a nurse. So Marc, you shared with me how you wear dual hats out there. And actually, I want to start on the positive side of that. You had shared very much that during this place of crisis right now, you've really have both everyone coming together to save lives out there and your own lives. Can you tell us a little bit about how cross-departmental teams are really changing the way they work so that there's better outcomes both for the population that you're serving and for yourselves?
Thank you so much. And just thank you for allowing me to share some of our story. One thing I could say, and maybe some could relate to, is I think for the most part before COVID, specifically, you had a lot of departments, and actually more so between professions, working in these silos, in these separate silos, nursing, physicians, and so forth. One thing I've noticed with COVID, with this global pandemic, we've had at the clinical level more teams, more people working together to identify solutions. Because I think right now it's not just we're here to take care of the patient. It's we're here to take care of the patients, but we're here to protect ourselves and our family. This has become a us against the world type thing, us becoming the front line, the stopgap, the protection. And to do this, us working to better as a team, being able to communicate in a way and that I have not actually seen us communicate before.
That's fantastic, Marc. And can you share a little bit more about what you're seeing right now? What are the ways in which I would say you're finding that nurse and doctors are collaborating? Maybe an example of that, and maybe where are there still gaps, right? Where are there still things where we can either go better on or want to accelerate and make sure we don't lose even amidst this crisis?
I just mentioned those two professions. There's so many more that are collaborating together. I see more, we're collaborating with environmental services and mental health. I think when it comes down to, there's a word that somebody had told me a while ago that says the person that's closest to bedside has the most information. You're there constantly. And I think right now we're starting to see that person being brought to that table. Where before you were asking, where's the nursing presence? Who's here? Can we get to the table? Can we speak? Now it's starting to say we need, instead of saying where's the nursing presence, it's who should be at the table, and automatically nursing is there. It's not trying to find a spot. And I think that's where the teamwork has improved more. You have what I've seen, our experience now on the clinical design, how we're going to, the flow, the patient flow, the protection, the utilization of PPE, even in the designing of the unit when we're going to plan B, if we have to expand, speaking with engineers on the flow and what works, what doesn't work. This is a safety issue. This is not a pride issue. It becomes where what I've seen now, there's not, I like to say there's not these silos, and there's not this, no one's worried about titles or positions. It's now we're a team. And does this work? Us putting ourselves in that setting and saying, let's walk through the flow of the unit. Where are the gaps? How do we address it? Who do we need here to help us address it? And so I've been, on one hand, very very proud of what I've seen, and very optimistic of what I've seen, where we actually have a real dialogue where it comes to healthcare. Who are the vulnerable patients? How do we address that? And it's not how do I, as one profession, it's how do we, as this group, address this? These are the issues. And that has been one thing that I've seen has been coming out more often. What I've seen the difference is between clinical and coordination. We're not so much so in clinical, we're seeing this really great teamwork. In coordination, we're not so much so, and we're still working on that, so that we do have decisions are not being made with those that are not, that it affects. In a coordination, you're still seeing some silos in there that we're still trying to see how can we best break that down.
Interesting. And Marc, I can imagine managing both the clinical side and coordination side, particularly in the time and place that we're in now. There's a lot around mental health and resilience as well within yourself and your team. So can you talk a little bit more about that, what you're seeing?
I can say right now, as you can imagine, the COVID-19 disease has become like the great separator, right? The clinical team, the nursing team, you are now forced to not only provide care, but you're also forced to become, I wouldn't say forced, but now you have become the person's family. You have become their mental health counselor. You have become pretty much everything to them at this point, because they have no one else to reach out to. They can't communicate with their family as often. You're starting to see the strain on them. They have the fear of, am I going to make it through? The patients have the fear about what's happening with my family members. And you, as the care provider right now, also are now dealing with your emotional fear, because you are either not having enough PPE, worried about your health, but also worried about your patients. So I think mental health has become such one of our actually number one discussions in our team meeting is how are we addressing the mental health of the patients? You have patients that, because they've had the COVID-19 diagnosis, have either tried to kill themselves. So you're having suicidal ideation. So we're trying to deal with that. You're having depression, increased anxiety, dealing with families' anxiety. So we have spoken to our mental health team to ask them, and they've provided training on psychological first aid for our patients, because they can't constantly come into the ward to speak, or the unit to speak to the patient. So now you become that intermediary. Before, where COVID, we had multiple teams. Now this has sort of come down in the clinical setting to one or two people that's working with the patients. On the other part of that, seeing so many patients that are sick, seeing so many patients that are not making it, that you have connected with, that you have fought so hard to save their lives, that takes a toll on you at the same time. And who do you speak to that about? And that's, do you speak to your family member that's already fearful for your life, that you're there? So you're adding that much more fear to them. So now you are still worried, and so on this point, you're worried about your patient, you're worried about yourself, and then this isolation that you somewhat have in who do you speak to. I think we are focusing on mental health counseling for our team, our staff, in dealing with the amount of negative outcomes we're seeing, and also for our patients. Right now, one good thing is we're learning from others around. We have discussed setting up a booth for families that can come in, and we'll put like a tablet or a monitor so that we can go inside the ward, the service, with another tablet and monitor, and so that the families can be on the hospital campus close enough to their family, but can't be in the unit, so that we can find a way so that they can connect. We're trying to find ways to debrief with our staff. So, and one thing that we've spoken quite a bit about is make sure to ask, do that mental health or that safety check. Are you okay? Not just like, hey, how are you doing? Are you okay? But are you okay? How are you feeling today? Talk to me. I am really here to hear you. And I think that has helped, because once you sort of taken off that that band-aid of protection, because we as nurses will joke in order to say, I've worked in critical care, and sometimes when you see a patient, they're like, oh, my patient is circling the drain. But it's not that you're not tied to that, but you have to have a certain level of disconnect. And to a point, you can't disconnect. It's actually, I wouldn't say disconnect, I would call it more you are compartmentalizing. And at one point you can't so much. And so asking somebody, are you okay, allows us to open up and share, I am not okay, but you asking might help me become okay, because that shows that somebody actually cares beyond the superficial level of how you're doing.
Thank you for sharing that, Marc. I do want to bring Jennie in, because I imagine I can hear the emotion in your voice, and thank you for what you're doing and sharing the bits and pieces there too. It's not an easy conversation, but one that we should recognize and address, both the additional toll around the many hats you're already wearing on behalf of the nurses out there. But Jennie, I know that you have a lot to say on this topic as well. Let me first introduce Jennie Joseph. I had the pleasure of meeting Jennie last year at Aspen Festival. She is the executive director of her own nonprofit organization, Common Sense Childbirth, and the founder of the National Perinatal Task Force, which is a grassroots organization to eliminate racial disparities in maternal and child health. She is a US British trained midwife, and she is a huge force in fostering safe and respectful childbirth across the US in what she terms maternal toxic zones. So Jennie, please share a little bit more about this topic as well, around how you stay connected and safety, both for yourself, but then also for your patients during a time when human connection is part of both what you may need and both also how you can deliver your care safely. Thank you, Jennie.
Yes, thank you so much, Alice. And yes, Marc, what amazing words you're speaking. It is so important to articulate what's actually going on. And you addressed so clearly the impact, not only on the patients, but on the providers. And, as midwives, we are all about connections. We're all about relationship. That's how we operate. That's who we are at our heart. And we provide the care around that, but it's always centered. We center the mom-baby family. And then we also make sure that they have that sense that they are absolutely able to speak, that we will listen, that we will hear them. This COVID-19 pandemic has so impacted many of us, in that when we aren't able to physically be in the presence of our patients, our clients, we now are pivoting and finding ways to create those connections anyway. I think that this is one of the most leveling experiences that any of us have had, whether from the population or whether from the providers. We are all the same right now, suddenly. And so where we've seen disparities, and we know why those disparities exist, COVID is bringing this even more front and center. If there's anyone left who didn't realize there were disparities, this will probably help you get there. And so we know that to address these disparities, what has been proven, where the evidence is that when you treat people with respect, when their dignity is maintained, when they are seen as human, they thrive. And I've been really working hard over these last few years, especially with my work in the grassroots with the Perinatal Task Force, to recognize that the providers need this equal level of care, support, and just nurturing. We all need to be whole to be able to continue our work. So in this pandemic, what seems to be happening is, in the midwifery field at least, we're finding ways to maintain and strengthen connections because we already know that that is the access to safety that has been missing in many instances, and that even inside of this new change, this new pandemic, we now have been able to show this midwifery model really works. This midwifery model is sound. So as a midwife practicing in the United States, I've got the access to technology. I can use the telephone. I can use the Zoom. I can use the internet. We are reaching our patients, and actually we're finding they're doing better because of being reached in a personal way, in a way that speaks to them as individuals and says, you do still matter and we care and we're here. So I think that with that effort put into reach and work with patients, we also need to continue to reach and work with each other as providers so that we can maintain those same safety nets so we can survive this as well and continue to do the service that we've been doing historically and definitely now in this pandemic.
Mm. And Jennie, maybe just to bring it to life a bit more for us, tell us a little bit more about, describe what it's like right now working in the low-income communities. You mentioned telehealth, and curious of your perspective, like, is it working for your communities? Yes. Where is it not? Is it broadening the inequities and the gaps in technological access, or is it actually helping? Give us a little bit more.
Yes. Well, it's both, actually. It's helping, and yet it's also amazingly causing barriers where we never expected those barriers to be. So we have, yes, where we do work with low income, but we also work with all demographics. And we see that, again, this pandemic has leveled everybody to the exact same place. Everyone is worried, everyone's frantic, and they need to know that they do have access and the connections that they can expect in labor or in pregnancy and postpartum. The telehealth has been the savior for our particular practice. We're here in Orlando, Florida, and we have a large population on board right now. Current census is around 180 patients, and we are able to reach them all, and it's working great. But then the other side, the deep structural inequities, the institutional inequities, and those continued historical inequities that have confounded us all this time, they come out right now. So for example, I'm unable to be reimbursed for telemedicine or telehealth through our state Medicaid. I've been told, no, midwife codes are not going to be reimbursed for telehealth, although the directive has been everybody go to telehealth where you can in court in order to maintain safety inside of the pandemic. Yet here we are as midwives being shut out of that opportunity to bill for the telemedicine care that we're providing. So we continue on. This is what we do. We don't turn anyone away, and we are providing that care, but we are not getting reimbursed. So that's an example of how structural, institutional, racial, and class disparities are there. It's not because of the woman herself or her condition or her lack of compliance. It's about the structural inequities that are deeply embedded in our system. So even inside of a pandemic, we are being shut out. We are not able to get the same level of support from our governments, from our states, as we would expect anybody else is able to get. And that really hurts because it harms the patient's ability. I'm a provider who'll say yes anyway. Majority of providers are saying, well, no, go away. We will not service you because we're not going to get reimbursed.
Thank you for sharing that story as well. Still much to be done on the policy side in making it work for everyone. We don't have, I want to leave room for questions. Marc, do you have I saw you nodding a bit there. Why don't I give you the last word before I open it up for questions?
No, just to go back to what Jennie's saying, sorry, just going back a little bit, this is where who's making those policies. And I guess who's at that table on the policy level. We are talking about the clinical level, and we're seeing the effects it's having on our patients, but how do we change that on the policy level so that these structural inequities don't continue to exist?
Fantastic. All right, so we're going to go to the QA section now, and for those who are participating, you can ask the questions on the box, and I'll read them out to you all. The first question is around self-care, and so either Marc or Jennie. How do you practice self-care as nurse and midwives during this COVID-19 pandemic and long hours of work? What advice do you have for nurses and midwives?
Jennie, do you want to go?
I'll go. This is a really important question. And so what, again, as I've mentioned, we have found that we must build our support networks ourselves. We have deep networks. We connect with each other often weekly by Zoom, by any way that we can, to hear from each other and really listen to each other's stories. We're suffering. I mean, there's no two ways about it. And putting self-care in the middle of this is extremely difficult. I will say, for those of us who have worked with particularly with disparities and these poor outcomes already, this is not new. It's just heightened. So we were already in action with structural support for ourselves, our agencies. We are financially strapped, those of us that are independent organizations, as well as we know that there's not the understanding, or not yet the understanding, of what it takes to maintain and support a broken system, and to survive that, as well as to be able to support the people who are suffering. We need justice. That's really where our support needs to come from. So we've worked hard to build our own networks of support and to keep ourselves uplifted, able to keep going by supporting each other.
I would say on two ends, because I work both administration sort of clinical. On one end, we've been trying to do is go out into the ward, and because again, the person that's closer to bedside has the most information, and go out into the units and sort of like pull out the staff and just talk to them, like have not this official, we're going to have this meeting, but like, hey, how are you doing today? What's going on? And then you get these great, like, hey, we have this frustration right here. There's a problem right here we're seeing, but no one's going to come tell you in an official way until you just sort of sit and you're like, oh, okay, let's see how we can work on that. And I think it's giving voice to the concerns that people have. So I don't feel voiceless in this battle. And on one way, on the other end, I think I have to keep going back. We try to find, we do a daily meeting now. And we started with prayer. Some of the team had asked in the beginning of this. And in the daily meeting, one of the things that we talked to say, like, hey, find a way to give a positive word to somebody today, anybody, all the nurses, just find one positive way, just so that we can constantly remind that we're in connection with each other, that we're not getting lost in this COVID and this craziness, because we're all fearful, but take a time and say there's a word of appreciation. We also encourage people to connect on social media, join groups, talk to each other. And one thing also is what I've done is develop a family plan. I call it my personal family plan. If I get sick, what do I do? I have a child, I'm a single mother. What do I do with my child if I get sick? Take that worry off. There's a plan B. So because we're here every day, but we're still worried about, will I catch this also? And so I have a friend that's like, one of my plan is I have a friend that's neutral. If something happens, they go to that. So at least I know that my family's taken care of if something happens to me also.
Great tips. Well, it sounds like from you both, there's things around recognizing and empowering by word and recognition. More to be done, maybe more from a formal perspective. It sounds like you've been innovating as nurses and midwives do, to address this on your own with your own teams and with your own support groups. There's another question here for you, Marc. Can you please describe what it's like in Haiti right now? What does the front line really look like? It sounds like you work in a hospital with Partners in Health that prior to serving in part, are you the only hospital that does this, and how's this playing out with COVID?
So far, we're one of the only ones that has the COVID unit. We have several places that are sorry, there's somebody go. We have several places that are isolation centers, but we are a treatment center and an isolation center. In Partners Health, we have 4 of our sites that are also identified that are prepared to treat COVID patients. Should there be a larger volume of patients that we're unable to handle at our hospital where I am right now. What does it look like in Haiti? We are on multiple, I have to go back to inequities and dangerous practices that are happening. One, I think not enough testing, the same way that we have many places. I think there might be an underreporting. So there's that fear there. We believe that also looking at who's being tested, are the testing being distributed equally? Is it the wealthy that's getting tested more than those that are exposed? Is it being more widely distributed? I think another thing that we're concerned about in Haiti, as we're trying to address the COVID on the primary care area, is, and also as in community sensibilisation. I always forget the word in English, sorry. So I don't know the word in English, sensibilisation, sensibilization, and getting the community to understand what COVID is, what's protective measures that you can take to protect yourself and protect us as healthcare. At the same time, understanding, and not to get too political, but we have to mention it, at the same time, receiving deportees coming to the States that have not been tested for COVID, that have been in COVID centers, in areas that have people that are COVID positive. So that's putting further burden on our system. We have had people that have already been from the deportees that have tested positive several over a week after they've come into country. So there continues to have deportees from the US. You're also having the border between the Dominican Republic. We're having 300 people crossing the border approximately per day. So that's another concern that you have. So while we're trying to mount the strategy and continue providing care for patients and acute care for patients, you're also in your head saying, how are we going to, what is this wave coming for us? Is there a major wave coming towards us, and how are we going to manage this? So it's on both ends. We're working on advocacy to see how can we stem the tide on other ends, but also provide care for those that have fallen ill and prevent others from getting ill.
Thank you. Wow. So we only have a few minutes left. I want to give you each the final word and maybe ask, with all this going on out here, first of all, thank you for doing this during a busy time. There's a lot of Q&A in here that we'll follow up with. A lot of thank yous also in there that I just want to share with you both. And maybe just last words from you both. How can we support you? What's the one call to action you would leave to this group of engaged colleagues on the phone? And maybe Jennie, I can start with you on that question.
Yes, I would just ask everyone to consider that we must not forget the mothers and the babies in the middle of this. Remember that before this happened, so many mothers and babies, so many mother-baby family were suffering regardless of where they are in the world, because maternal health and maternal morbidity and mortality has just been so overlooked. This is not anything new, but now in this time of COVID, please consider, how are your local communities managing the mother-baby issue? Is everybody safe? If you can have any way to intervene, to support, to talk to your legislators, keep mother and baby centered. Maternal health matters.
Thank you. And Marc?
Exactly. Exactly. I think going back, what can we do? I think, wow, there's a lot, but to bring it down is really keep an accent or keep a focus on those health inequities, and how do we keep addressing or keeping in the forefront resource allocations with the limitation of resources that we have, making sure that people of color, people with disabilities, people that are normally in a marginalized community are not those that are receiving, quote unquote, the short end of the stick. They're not the ones that are putting to the side. Also thinking about, as Jennie had said, that we don't have more cases of morbidity and mortality because of COVID, but not directly related to COVID because they're not receiving care. And I think one thing I would say, what can we do? Call to action is, do call a legislator. We have, visit our websites and see what else can you do. Right now, I have to keep going back to the mental health aspect of it, because as we're taking care of our patients, call a nurse, give them a word of encouragement. There was actually a campaign that started at the beginning of this COVID where it's they listed 3 people, and you just sent a word of encouragement to one person on that list, and you kept it going. You listed another 3 person. That person chose the top of that list and then sent a word of encouragement to the next person, and it kept on going. So I ended up getting, like, on random days, like 3 words of encouragement that you're like, oh, wow, thank you. And that helped when you had such a crappy day that you opened the message and it was nothing else but this word of encouragement. You're like, all right, I can do this. So
Amazing.
maybe that word can help somebody on a really horrible day.
So let's make sure we take those big and small actions within this group as we close out. Send words of encouragement to the health workers and nurse and midwives that you know. Write to your legislatures. Don't forget about essential care during a time like this, which oftentimes may also have health impacts that are not directly related, but are related to COVID. Thank you, and a big round of applause to Jennie and Marc for joining today. Aspen and the team will be sending out more details on both of your organizations and ways to support. So thank you for your time today and stay safe.
Thank you. Bye-bye.
Thank you.